So how can we do inspection? Per speculum examination, by manual examination, per rectal examination. And also we saw that through the cornices, we assess the involvement of the pelvic cellular tissue or uterosacral ligament or any other ligament affected or not. So by manual examination is so important under general anesthesia. And another is that is you should describe every point of the inspection symptom and sign. Why there is foul smelling discharge? Not always. Patient may come also asymptomatic. And incidentally diagnosed patient. When we see the cervix, then we suspect something. Then discharge. That is two types of the carcinoma. What is carcinoma? Definition of the carcinoma, what is sarcoma? Malignancy of the epithelial cell. And sarcoma? Malignancy of mesenchymal tissue, connective tissue. Okay, so here, where it started, most common is squamous cell carcinoma. Most common is 90% is squamous cell carcinoma, and others adenomatous carcinoma from the endocervix. So that is squamous cell carcinoma, where it started from the squamocolumnar junction of the cervix. Okay, and others which is easily diagnosed. Adenomatous carcinoma from the endocervix or squamous cell carcinoma. You can see easily the ectocervix. That is from ectocervix, squamous cell carcinoma is more common, and from the endocervix it is inside, so it is not easily seen. Endocervix, you can see the endocervix or not? We cannot see the endocervix. We can see only the ectocervix. So tumor from the endocervix we cannot see. So outcome of the endocervical growth is so bad. Just we can see the barrel shape of the cervix, broad cervix, no growth. But why no growth we can see? As the growth is inside, so we cannot see. You can see the growth from the ectocervix. Okay. And why there is bleeding on touch? You see the growth, suppose the growth is different types. That is more proliferation of the cell that is formed cauliflower-like growth. Younger women are more affected by the cauliflower growth. And another is infiltrative, that is going inside, infiltrative side. That becomes more harder. And another is ulcerative, it is breakdown, surfaces breakdown, and cervix is so much to the surrounding structures and thinner. So ectophytic growth, that is proliferative, cauliflower-like growth. Another is infiltrative, hardening of the and mostly indurated structure. And third is the ulcerative growth. Okay, it is asked in the exam what are the naked eye inspection of the growth of the cervix. And others is why there is foul smelling. Foul smelling, you know, the growth of the cervix. There are so many necrous tissue. There is devascularization and necrosis of the tissue. In necrous tissue, what type of organism grow? Saprophytic organism. In necrous tissue, saprophytic organism is growth. And saprophytic organism, you know, the smell of they produce mostly hydrogen sulfide. And so that more foul smelling. And as you know, as there is always growing tissue, so there is more discharge. So these are the explanation. And others, when you, in our country, how much common, the carcinoma cervix, so common. But nowadays, earlier diagnosed and we can manage earlier. Suppose after diagnosis, if we suspect stage 1, then what are the management, stage B, what are the management, 3, 4, what are the management, you should know. So stage 1, A1, A2, we can do simple hysterectomy, or trachelectomy. Trachelectomy means removal of the cervix. And another is stage 1B. We can do the radical hysterectomy, that is called before Badrunnesa hysterectomy. Badrunnesa, you heard the name? Badrunnesa hysterectomy. The word is W-H. Badrunnesa hysterectomy, I will write later. That is, what are the components? Total abdominal hysterectomy with, now you complete from up, hysterectomy, bilateral salpingo-fructomy, then upper half of the vagina and pelvic cellular tissue, and draining lymph nodes. Very good. What are the lymph nodes? Draining lymph nodes here. At first, draining lymph nodes of the cervix mostly go to the inguinal lymph nodes, that is obturator, inguinal lymph nodes mainly, then goes to the inside, obturator lymph nodes and common iliac lymph nodes, internal iliac lymph nodes, and lastly to the para-aortic lymph nodes. So all the draining lymph nodes are important for radical surgery. Okay, so obturator, inguinal, para-aortic, all should be removed during the surgery. So these are the radical surgery of the operation. So what are the actually management others? If advanced stage, if beyond stage 1B, then surgery not appropriate. But in any stage we can do radiation. Radiotherapy we can give at any stage. But surgery, we can do surgery, that is radical Badrunnesa hysterectomy, we can do up to stage 1B. And another operation, the pelvic exenteration, that is removal of the all pelvic organs, that is another operation. But in the management, so what are the, that is number 1 radiotherapy, number 2 surgery, number 3 chemotherapy, number 4 is combined. Either radiation and surgery or chemoradiation. Chemoradiation is nowadays more common, chemoradiation. Okay, and another, if you manage, and if I want to know one chemotherapy, that is cisplatinum, 40 mg per square meter body surface. Cisplatinum is mostly given in case of carcinoma cervix. And you should know the complication of the surgery, complication of the chemotherapy. So, during surgery, what are the most complications? Hemorrhage, and then injury to the bladder, rectum, and fistula, and infection is so common. Lymphoedema, and you should describe. And after operation, abdominal distension, paralytic ileus, fistula also can be formed. And others, complication, radiation, you know the complication of the radiation, chemotherapy radiation. There is nausea, vomiting, and so you should know also about this. Okay, then I proceed. CT scan of the, that is, why CT scan we do? CT scan mostly we see the CT scan for to know the lymph node affected or not, mostly lymph node, to see the lymph node. And MRI is done for the extension of the growth. MRI is done for extension of the growth. Lymph node. So treatment of the joints depends upon this, and along with the treatment we should do proper counseling, anemia, malnutrition we should be corrected, and like this. So these are also other management, cone biopsy, radical trachelectomy, and like this. Cold knife cone surgery in the pre-invasive form. In the pre-invasive form, we loop excision. Just to remove the cervix, cervix, it is. When we can need to keep the uterus, when patient is nulliparous, she needs children, babies, so that in that case we can do like this. This is loop excision, electrocautery by the loop excision. This is Badrunnesa cystectomy. Huh? All this we should remove this. These are draining lymph nodes. Radiotherapy. Now we can. You should know something about the radiotherapy. How it is? That is brachytherapy near to organ. Teletherapy is away from the organ. And brachytherapy, there is 3 systems: Stockholm, Paris, and another. Others is forget. There is 3 systems. In the 3 systems, the radiotherapy, brachytherapy is given directly. This is teletherapy. Intracavity. This intracavity system is in 3 different ways. Stockholm, Paris, and another their system. And interstitial brachytherapy, that is put on the paracellular tissue. That is, this is interstitial. That is paracervical tissue implanted the radiation. Chemotherapy. So this is important, follow-up. After any management, we should do the follow-up, and here carcinoma cervix is that is lifelong follow-up. So this is prognosis. You should know the prognosis. After treatment and after management, stage 1, 5-year survival rate is, you should know about this, 80 to 90%. So survival rate is high, 80 to 90% after management. Stage 2, 50 to 65% 5-year survival rate. And stage 3, after management, how much? Survival rate how much? 25 to 35%. And stage 4 is less than 15%.